So we are moving on with the day, and the next session, session 3, is going to be the awards presentation for the John Fitzpatrick Award. So it is a true honor to introduce Professor Michael Stehler from the Ludwig Maximilians University in Munich as this year's recipient for the John Fitzpatrick Award. Throughout his absolutely remarkable career, Professor Stehler has shaped the care of patients with kidney cancer like few others. He has dedicated himself to both the surgical and oncological management of these patients with deep compassion and commitment. Much of what we now consider as standard of care in the management of kidney cancer bears his influence. What truly distinguishes him is his holistic perspective. In the morning, he will go and treat patients with small renal masses. In the afternoon, he will see patients with perioperative kidney cancer. He will see patients with systematic therapies, all the way accompanying them through end of life, ensuring dignity and excellence at every step. In addition to his clinical and scientific impact, Professor Stehler has mentored generations of urologists and uro-oncologists, generously sharing his knowledge and values and helping to shape the next leaders in the field. I have known Professor Stehler for over 10 years now, and he has really introduced me and shaped the way I treat patients and the way I approach oncology. His mentorship has profoundly inspired me and the way I care for the patients and conduct research. He's also not just a clinician, but a father, a stepfather, a husband, and he's basically just the most amazing person I know. So please join me in celebrating an extraordinary person and pioneer as he receives this year's Fitzpatrick Award.
Can I get the slides here, please? All right, okay. Bernadette, thank you so much. I think you picked the wrong guy, but I'm still gonna take that award. When I was thinking, what is this about? It's about legacy and innovation in kidney cancer that I wanna talk about, and you see a picture of my grandfather on the mother's side here with his sister. Why do we go back that long? It's Europe, we all go back that long. And my great-great-grandfather actually did the first German mercury thermometer on our industrial scale, the first light bulb, the first thermos jug ever, and he was with Konrad Röntgen inventing the X-ray tube. Actually, he was the one who produced it, and I'm kind of proud of that. His son, my great-grandfather, worked for Zeiss, the optical company, and while he had a ticket in first class on the Titanic, they deployed him off to St. Petersburg to sell microscopes, lenses, cameras, and further sent him to Tokyo in Japan, which was kind of uncommon those days. And he started the Japanese camera business over there. Not so sure what to think about that today. My grandfather, on the other hand, wanted to become a surgeon, and he was the first to ever publish a book on cystoscopic surgery in Germany. He founded urology out of surgery, was the first German of urology, and I found a report on a kidney cancer patient where he did metastatectomy, and that guy survived for another 9 years, which was kind of impressive being a little boy. And he did something else. He taught a couple of Americans how to do surgery because they came to his place during the war. And there is a guy called Bricker, and you all know the ileal condit that he learned from my grandfather. My father also was a urologist. He introduced the levels of caval trombi in 1978. You know them now as Mayo classification, which came a little later. He taught Andy Novick how to do partial nephrectomies. He established the first German kidney cancer database. I might have helped him a little bit with that. And he taught me how to drive cars fast, which I still do. Here are those levels, and you don't see a big difference to anything that happened before. Important to me are my patients, wherever I can meet them. And more patients, and you see even little boys being patients, we take them out to make their lives better, and I really care deeply about them. I also care deeply about all the colleagues I get to work with and the collaborations we have with them and all the meetings, and I like my work family a lot. I also like my home team, and you see Bernadette here with some of the teammates, and it's a crazy team, but it's a really great team, and they really thrive greatly. I love my personal friends, and what we do together, it's really important to have that time outside of your work, and of course, I'm dedicated to my family. I also do a little bit of science, and I'm guilty of all these things here where we publish papers and don't know how I got it in there, but I took it out. There's variation how we do things. And of course, we are always better than you are, and you're better than us. That's why we publish and fight each other. I want to focus a little bit on the people who influenced me deeply. First of all, Brad in the back. And we had a conversation, you probably won't remember that, it was years ago, where we were talking about your score, and you said, it's the best we have, but if you want, you can make it better. I never managed to do that. Rob Uso also, I was so mad at him because he's like, I'm just gonna clamp that kidney forever to preserve it. I don't care about any kind of damage. It will still be better than resecting it. I completely disagreed. Until some years ago where I learned, yeah, he's right. Better preserve the kidney, and it doesn't matter how long you clamp it. Bob once took me on a bus ride, and he's like, hey, I'm a clinical trialist. How can I help you? And what is of interest to you? And that kind of relationship prevailed over the years. Probably none of you knows this guy. It's Alex Muachevich, and he and I were the first to ever treat a patient with radiosurgery, and we kept doing it. Now we are at the 500, and he said, if you really want this and are sure of it being good for patients, we can give it a shot, and he's a neurosurgeon. I left my work with the EIU guidelines, and I want to thank Axel Bax, walking over there, and Barry Lungberg, who is not here today, who always told me, we have to be open-minded and come to an acceptable consensus for everyone. I just wanted it to be a consensus for myself. Tom Powles is also very influential to me because we fight a lot. And he said something during the guidelines meeting that you probably aren't aware of, which is, if you can't find consensus on recommending nephrectomy for a cure in the guideline, we can all go home. We all went home, but we put the recommendation in, although there's not a lot of evidence to really prove it. There's no randomized phase 3 trial to show its benefits, but sometimes we don't need that. Chris Wood also is somebody who deeply influenced me, not because we shared the passion for athletic sports, but also because he said, you're even more aggressive than me with your surgery. Maybe I have to rethink what I'm doing. I think he meant I have to rethink what I am doing, but we came to the conclusion that we're both right. Jose Karam is also a good friend of mine, and he always reminds you that you have to bring your A game for your patients, and that they're first. This guy is Ethan Dervish. We have something going on at the AUA meeting that we call Renal Wars, which is go out there and challenge people on their research if it helps patients or if it's just helping their career. And a lot of people that I met during my career said that one sentence to me, which is, here's why you are wrong. And I like to be wrong. I also like the cooperations, whether it's online or offline, with a lot of people coming together with this quote from Alex Kudikov, fascinating how bright minds see things differently based on the same data. It takes me from the legacy to the future, where I believe we need to understand which patients will recur and which patients will not. And you've heard it today that this is an unsolved issue. I do believe that pathology needs to abandon classifications on size, histochemistry, and shape, which they established around 1886 and not in 2025. And introducing genetically defined RCC subtypes without general genetic classification of all RCC specimens does not seem to be a sustainable or helpful effort for either us or our patients. So I need them to actually change that. We need AI, and AI can inform us about some things that we didn't think of previously. And this is an analysis that we did where actually just the location of renal tumors predicts the prognosis of the underlying disease, which is something that surprised me. And something that I didn't like to see actually is that your outcomes in terms of your survival are heavily related on your surgeon, your destiny. There are also some things that we have to be more critical about, and we all rave and are happy about the data on pembrolizumab, where we see, hey, this is an overall survival benefit, actually not for the patient, but for all patients that are included in the trial, but it's only 8%. And nobody looks at this little field here, which is about 3% of patients who did not benefit from any of our efforts. Why did we put them through this? Why did we put them through surgery, through systemic therapy, without any benefit? And I think we need to be more thoughtful in identifying patients who could benefit from what we're doing. Future unmet needs are that we have an issue with sample sizes of single centers who might have really good information, but the numbers are still too small to identify meaningful trends and principles. If you come together as a community and pool it, you will see more than if you do it yourself. Analysis of publicly available databases like SEER lacks sufficient pathology and clinical information for a better understanding. So I despise those analyses, which can only inform us of some really superficial trends. We need data of outliers, like super responders or super progressors, because they're more helpful than larger series of median patients, but they need to be brought together to achieve a meaningful sample size to reveal the underlying mechanisms of those patients and actually help us understand what's going on with their disease. And to me, the key question is, why do patients metastasize after 30 years? Because to me, those metastases are not the disease. They are the symptoms of the disease. And maybe that's why we haven't found a cure so far, because we're looking at the symptoms and not of the cause of the disease, which might be a breakdown of intracellular communication systems within the whole organism, rather than something that goes wrong in those cells. I think that further development of Me Too drugs should be abandoned, and focus should be put on new mechanisms of action, multimodal therapies like integrating radiation therapy, combinations of drugs that are not curative, and we're not there yet, will not improve cure rates, but increase therapeutic burden on patients. The perspectives for patients is that we need to aggregate their patient voices, highlight the need for better therapies and support. We need to have international cooperations and teamwork to drive the progress in care, and we can achieve that by personal connections which are coming from friends and colleagues. And when I look into this audience, you're all my kidney cancer family and therefore friends. And keep in mind, today is the past. It's not the future. So please collaborate, fight, improve to get better. And this talk would not be finalized without thanking my wonderful wife for all her support, her challenges, and her devotion and love to me and patients in what we do. Thank you so much.